I had to do it. There is no choice. Operating such a patient is putting the whole medical team and the whole hospital campus at risk of COVID spread. Patient is getting more attention at present.
VIP attention. Huh?
Yeah.
With a population of 130 crore, India has never been able to keep pace with its medical needs. Healthcare system crawled over 70 years from metros to town, but the quality compromised per mile. The best facilities are at the limited places, but for the few. The political will was never for healthcare, but healthcare is for all. What we always afraid of has comforted us today. The services which could barely support us has been diverted to COVID. What about the distressing ease, that is, disease, which need immediate attention in the midst of vanishing hospital beds, medicines, and even life-saving oxygen? We are trying to bring to you a light of hope through an interview with Dr. Kapil Dev, senior laparoscopic surgeon at Fortis CDOC, Nehru Place. He has a rich experience of 30 years of all types of surgeries. Dr. B.V. Gupta, a renowned family physician, a medical writer, a philanthropist, social worker, and visiting consultant to various government organizations like TRI, Competition Corporation of India, to name the few, will be interviewing Dr. Kapil Dev.
Good evening, friends. It is a very good opportunity for me as a family physician to try to get answers to many questions which have been in our mind. And incidentally, only last week, I had a problem with a patient who was suffering from severe impacted gallbladder pain. So I did not know where to send. Eventually, I said, okay, you go and find your way out, which is not the way that we have been doing with our patients. So I am very happy to know that there are some institutions, there are some doctors who are still working in these trying times. So Dr. Kapil Dev, my first question would be coming from that experience of mine. Like in these days of COVID, when we are extra cautious, patients are also reluctant to go. But in cases of emergency, in cases of seriousness, like impacted gallbladder stone, impending appendix perforation, or ulcers or trauma cases, how do you manage to do all these surgeries?
Mr. Gupta, emergencies are emergencies, whether they are medical or surgical. So, emergency medicine at present, in the present scenario, is not there at all. It is zero. A patient dying from liver failure or cancer or appendicular perforation or even gastroenteritis. I'm talking about gastroenteritis, uncontrolled diabetes, uncontrolled hypertension, CVA. So all these patients are not getting the medical because the whole medical system is loaded with only one thing, which everybody knows, that is corona positive patients. So I am working at Fortis CDOC Hospital, Nehru Place. It is a purely non-COVID hospital, and I am dealing with all such emergencies. We do not allow any COVID admission, and for that matter, even if the patient's COVID report is negative, RT-PCR is negative, and his breathlessness is there and his oxygen saturation is less than 96%, we do not entertain or admit such patients. When a patient calls me, like if you have called me for the gallbladder today, step one is we check the oxygen saturation. Despite any test, if the oxygen saturation is less, we have to refuse the patient because most of the cases with negative PCR and a low oxygen saturation without any history of COPD or with no other reason are most likely to be COVID on a CT scan. We do a rapid antigen test. Rapid antigen test, we do it outside the hospital, like in the driveway or in the, just at the entry, at the reception. It is positive, of course, we do not admit. But if it is negative, then we admit the patient and start our fluids and investigations and everything. And if the patient has an RT-PCR, which is negative, we go and we operate immediately. If the patient does not have an RT-PCR, then we need about 12 to 13 hours, because from our center, once the sample is picked, we get it in 12 hours and we operate the patient next day. And somehow we are able to avert the damages done to the patient's life and body for 12 to 24 hours by admitting him and keeping him in the hospital with a proper medical aid.
Suppose there is an emergency and the patient turns out to be positive by rapid or by any other method or even by CT scan, then what happens to that patient?
So there is no choice. Operating such a patient is putting the whole medical team and the whole hospital campus at risk of COVID spread. After all,
Thank
the patient will need GA. GA means intubation. Intubation means all whatever the patient is exhaling is going to the anesthesia machine, and it is going to circulate everywhere in the hospital.
The surgical procedure has been done and the patient is there for the aftercare. I think that has got no implication because of the aftercare of the patient during these times.
Aftercare is the same as in the normal times. For follow-up, we can never know whether he is an asymptomatic carrier. So after the surgery, the patient goes home, and once he has to come up for follow-up dressings and other things, we try to keep the follow-up wide, very wide. Suppose I want to call the patient after 5 days, maybe I call the patient after 8 days. I can talk to him on telephone. And then at follow-up, if the patient is saying, I have no fever, I have no complaints, then there is no risk in OPD.
There is also a query that suppose when we are done the surgery and we are advising patients about the anti-inflammatory and the painkillers and the antibiotics, are we advising them any antiviral drugs?
Not at all. Unless proven, for that matter, any medicine should not be given, sir.
Okay.
Unless my blood picture is showing a low count, compromised immunity. Suppose I find after the operation I got a CBC done and the leukocyte count is 3,000, then I may suspect some viral infestation. There has to be a documentary evidence of starting any antiviral,
which normally would have been high post-operative.
Yeah, definitely.
What is the whole gamut of surgeries that you are doing or you are able to do in these times? All surgeries, or there
I'm
is
able to
still
do all the surgeries. Today I had to do an amputation. Yesterday the patient was admitted. We did an antigen. We did a PCR. It was negative. And today we had to do, because it was gas gangrene, non-functional limb. And medical legally, I can't send the patient anywhere unless he is COVID positive. I had to do it. There is no choice. As the volume is low, like suppose I have got 10 beds on a floor and I've got 4 floors in the hospital. Right now, I have only 4 beds occupied. Patient is getting more attention at present.
VIP attention. Huh?
Yeah, so my second floor today has got only 4 patients which have been operated by me. So all the staff and nurses are concentrating on that only, because there are no medical admissions. And I would request everybody that the places where there are no COVID admissions, we should give them medical aid even for medical admissions. Gastroenteritis, why not? Patient may go into shock, hypovolemic shock.
Pre-operative assessment of these patients.
Sir, pre-operative assessment is routine tests only, viral markers and all the general condition of the patient. And pre-operative assessment, just COVID is added. It is as routine only. That recently they have started this TrueNat, which is extremely reliable and which can give the report within a very short time, and we can operate the patient. And TrueNat is the false positive and false negatives are very low. There are no false positives, false negatives in the TrueNat. It is totally genetic testing.
And what about the very small surgeries like INDs and all that?
That
I know it might be.
Yeah, no, why not? I do it in my minor theater, and where I don't bother the patient to get a PCR or antigen test done. A patient coming with a small abscess on the nail, how can I ask him to get an antigen done and PCR done? That I drain straight away. So for that matter, in routine also, when we are doing minor procedures in our minor OT, which is like an office as a dressing room, sometimes we come to know that the patient had HIV or HCV or hepatitis B later on.
Yeah, that is always
or
there.
whatever. So minor surgeries we do in our dressing room as an office procedure without any extra protocol of testing for COVID. So my point is, the patients at this time during the panic of Corona should not suffer by thinking that the certain hospitals that no hospital is doing routine work. We are doing routine work, and it's going fine.
Even I was under that impression. Dr. Kapil Dev, I think it was a good talk with you, very small and crisp. And what I feel elated is that now I know that where I can send the patients of normal surgery, minors, major, in these times where we have the impression, the patients have the impression that they cannot go to any hospital because every hospital has some beds for COVID only. So they are sort of a tainted type of hospitals. So it is nice to know that Fortis CDoc is a non-COVID, purely non-COVID institution, and you are taking pains to take care and do the surgeries for these. Thank you.
Thank you so much, sir. Thank you.